haven't found exactly what I want. They don't know how to word it, so they find this moving thing I want. Can you just like describe it? Maybe like start with and like yeah. So that's what I'm just struggling with, just finding that in my existing.
The now and the future. We're delighted to see so many faces in our audience, and also we have webinar participants joining us. So thanks for joining us. I'd like to start the day with some welcome, some acknowledgments, and then give you a layout for what to expect for the rest of the day. So first of all, welcome to everyone here. We have representatives, we have clinicians, we have students, we have people from peer support programs, we have people from government. It's fantastic to see groups from so many different diverse places all joining us. Also, welcome to our webinar participants. So we've never done a webinar before, and we're quite excited. We have people joining us from around the province, representing all of our health authorities.
Sally says hello.
Fantastic. We have over 100 folks from Penticton, at least 30 folks that I know of from Vancouver Island, Fraser Health, Vancouver Health. So it's fantastic to have all of you joining us on webinar for the morning. We look forward to your contributions. And some acknowledgements. So today is possible because of the work of PSR BC. So those from PSR BC on the board, if you could please stand. Very good. I think some of them are outside doing registration. There's a few more. So those folks, throughout the day, if you have questions, if you have feedback for PSR BC, please come and talk to them. And I don't think I introduced myself and Regina. So we're the co-chairs of PSR BC, and we'll be your MCs today. And also So an overview for the day. We have an exciting day ahead. The morning will be in this room. We're going to start off the day with Higginbottom speaking about the PSR Service Framework document. So that's an exciting new document, and we're all excited to hear about it and how it'll impact our practice. We'll then have a break out in the lobby. Following the break, we'll be back in this room for a panel discussion with experts discussing the implications for the new document. Sure. In the afternoon, right up there? In the afternoon, we have breakout sessions, and so those sessions will take place every door has a label, so you can find out what's happening in those rooms. And we have some fantastic speakers representing the different domains of PSR. So we have someone speaking on leisure, on supported education, 2 panels on employment, 1 on health, and 1 on recovery in a tertiary setting. So thanks for all the presenters, and we're delighted to have you representing a real diverse PSR for all of us to hear about. Following the 2 breakout sessions, we'll meet again back in this room, and Debbie Fasula, who I think a lot of you probably know in this room, but for those of you who don't, she's a real pioneer in peer support services, and she's going to be talking about the accreditation work for PSR she's been doing, which will affect peer support nationally. So we're really excited that Debbie will be joining us this afternoon. It's a huge advancement for peer support and something we're really excited to be a part of. And then we'll close up and we'll be finished by 4:30. So that's a bit of an overview of the day. A few housekeeping notes. Bathrooms are down the hall for those of you who didn't find them. We will have lunch served, And I didn't mention, at lunch there'll be an AGM, and that'll be in this room, and that's a bit, all are welcome, and it's a chance to find out a little bit about what we do on the board. Observers, interested observers, people who may want to join PSR BC, you're all welcome.
Joe, step over this way. Sorry, just for the guys online.
All right, hopefully you can all hear me. Phones off. That was the last thing I wanted to say as far as housekeeping. So with that, again, we warmly welcome you all, and I'd like to hand over the microphone to Regina, my co-chair and MC for the day, who will introduce the first speakers.
So thank you very much, Jill. Appreciate that. I will do my best to speak directly into the mic. Thanks for those of you who are on webinar. Thanks for your patience. I know sometimes it's hard to hear and get the context of what's going on, but we're thrilled. We understand we have about 150 people at least on webinar. So with that presence and your presence here today, it has exceeded all of our expectations. You are a community of practice, and we look forward to working with you in the months and years to come. So thank you very much for your efforts in being here electronically and in person. Thank you. Also, just want to do a little bit of a shout out to some people in the audience. I noticed a number of people who receive services in the audience, and that's kind of thrilling for a PSR organization. We know that there's some family members here. We see many people delivering services. I see some administrators, not to put people on the spot, but I see Anthony Neptune, or I did see him. I don't see him at the moment, so thanks, Anthony. Simon Davies from Vancouver Coastal Health, so thanks for your time and effort to be here. Also notice some people from the ministry, so I'll just give a shout out to Chris Laporte. Not sure if you want to stand up, but Chris is Senior Policy Analyst with the Ministry of Health, so really delighted to have that kind of support today. And last but not least, it's my pleasure to introduce Garrett Vandelier, also Director for Ministry of Health, Mental Health and Substance Use. So thank you for being with us today. LinkedIn is a terrible thing, but through looking at LinkedIn, I learned that you have committed at least 37 years of your life to mental health. So just wanted to do a big shout out for that, because I know that you have been a project lead and a support in many areas of mental health that go from managing anxiety to suicide prevention. So we are really delighted and honoured to have you to say a few words to open our conference this morning. Thank you.
Thank you very much, Eric. I just want to say how exciting this is in the actual history of psychosocial rehabilitation in British Columbia. When I started my journey 37 years ago, there was no opportunities for rehabilitation. People actually did not have a future other than to live in an institution or in an institutional environment. We've gone through many journeys in British Columbia in terms of supporting PSR, where we're focusing on employment, on leisure, on work, basic living skills, but we also included wellness, which is so important. We often don't recognize the importance of nutrition, exercise, and working in a more wholesome way around being more active. And my journey in PSR started, I think, very early when I learned that often people who had basically a care plan developed. The care plan was often developed for the person and not really for having any input. I think the time has changed where the care needs to be clearly directed by people who have the experience of mental illness, with support from families, from individuals, and from the mental health and substance use community. So this particular initiative in terms of development of a PSR service framework started in 2010, where the Ministry of Health clearly has made a commitment that psychosocial rehabilitation is a core component throughout the continuum of care for people with mental health and substance use problems. That's a very important decision, because historically PSR was kind of an add-on component. We recognize as a core service. In order to move forward, the work of Dr. John Higginbottom and his team and the health authorities, ministries of social development and innovation, as well as education, have been working on finding out what is the ideal system of care that outlines the core components for PSR. Secondly, an environmental scan, what services are available right now that are really consistent with the evidence, and finally to do a gap analysis to find out where we move forward in areas. And I must say that while we're doing all this work, technology is also moving fast forward. Can Assist, for example, in the University of Victoria, are now developing platforms, electronic platforms, to better support people around living more independently. So how exciting, not only to use the work of PSR Canada, but also other organizations to go beyond our thinking. So I'm very excited about this, both not only people in person, but people in webinar throughout the province, that now as a result of new technology can participate in this. We have, in addition to the development of service framework, we have recommended the development of an advanced practice, which includes a community practice, research, education, training, standards development, as well as providing guidance to the various ministries in terms of what's working well and what needs some changes. So I think this is an historical moment in the history of PSR, because we actually brought everybody together on this journey, and I think this is the first time that we actually have the community practice come together. So I hope you will continue your interest in this area, support this area. We need input from people with lived experience, from families, from policy makers, from researchers, in order to come up with the best possible outcomes. So thank you very much for attending this and supporting this.
Thank you very much. I don't know about others, but I got a little goosebumps over my little body thinking, my goodness, this is a momentous occasion. Thank you for that wonderful introduction. You got us all stirred up. Thank you. Before we go any further, I would like to just make a little shout out to Vicky Hewell, who is the president of PSR Canada. May I please ask you to stand up? Thank you.
I know where the party is in Canada.
So for those of you online who might not have heard that, Vicky's saying that we're the party house in Canada. We know that. So thank you very much for making time to come and be with us today. For those of you who might sign up to be a new member today, Vicky's a good person to talk to in terms of understanding the benefits of membership. So thanks again for attending. It is now my great honor to introduce to you Dr. John Higginbottom. Many of you might know him as Associate Dean here at Douglas College. Perhaps you know him through UBC and his long-standing teaching abilities. We've been talking numbers today. I think that was 27 if I got it right, but a fair chunk of time teaching new medical students. You might know him as co-chair of the Alliance, or what you might not know is that John has a keen interest in flying small aircraft, a passion that he has also brought to Douglas College here. So he is a man of numerous talents. We are here to talk about the new framework, a very, in my opinion, exciting document that I think really, in a very practical way, helps us to understand how we may participate in the transformation process of our mental health systems, to systems that we hope are more evidence-based, are kinder, and really meet the needs of people receiving services. They look at outcomes of things that matter. This is a momentous occasion, and I just also want to say and acknowledge the work from many funded agencies, from people receiving services, from the various health authorities who worked tenaciously to make this framework document happen. It is truly a collaborative effort, and I know that it's going to lay the framework and the groundwork for our next steps. So it's with great pleasure that I say hello to John, and he is going to just walk us very briefly through this document, which we hope will be released in the very near future. Thank you, John.
Slowly and clearly into the mic. Some people say it's really good, some people say it's not good. So, take it for good.
You're really close, John.
Close and comfy with the mic here. So, good morning, everybody. It's wonderful to see this turnout, and particularly wonderful to have people attending by webinar this morning. So welcome to all of you. And as others have said, this is quite a historic moment because it is a real milestone, I think, in the history of the development of PSR services in BC. Because this is really the launch of our advanced practice. And as Garrett mentioned a few minutes ago, the advanced practice really exists to support the field, community practice. So, how's that? The advanced practice really exists to support the field. So you're the inaugural meeting of the community of practice. So put in your calendars at the historic moment here. It's a real challenge to do this presentation this morning. I've, of course, done many presentations of this type, but I have to tell you that one of the challenges is just having to sit. Any of us who do teaching really hate sitting and talking to people. It's really not the best way to do it, so sorry about that. But the limitations of the technology are that I have to stay close to this mic and pretend I like it. The other major challenge is that I've really got a huge amount of information to convey, and having said that, I've actually had to cut some major chunks out just to fit it into the time available this morning. So I'm going to be going quite quickly. What I can tell you, if you're worried about getting notes or you just kind of lose track or zone out after a few minutes of this, all of these slides that I'm going through this morning at great speed are going to be on the advanced practice webpage. We have an advanced practice webpage up and running. It's turning out to be quite a classy webpage. We encourage you all to have a look at it, and these slides will all be on the advanced practice webpage this morning. So without further ado, as others have mentioned, what we're really going to focus on this morning is the evidence base for PSR. And I think most of you in the room here know that PSR is an evidence-based practice, and or said it's an evidence-based practices and approaches. And that's one of the really important things to know about PSR. The fact that there's a very substantial evidence base, and all that we're going to be talking about are either what we call best practices. Best practices are practices which have a great deal of evidence supporting them. In some cases, the evidence has been around for 30, 40 years. And then we have what we're now calling promising practices. There's less evidence for supporting those practices, but there's still enough evidence to suggest that they are quite promising. So that's what we're going to be looking at in this. But mainly it'll be best practices. Okay, my slides can move forward. Team effort here. We're all on a learning curve, so I apologize for this. So, again, some acknowledgements here that you've already heard, actually. So we're going to go right into the part of the presentation here. So, I'm going to start off, and some of this is actually taken from the framework, which I'm happy to report will be coming out fairly soon. I know that there's great hope that the framework will be available pretty soon. So, and I'm not going to bore you by reading through all of this. Again, it's going to be available, but what is PSR? Psychosocial rehabilitation, also, which is referred to as psychiatric rehabilitation down in the States, is what we call it there. Promotes personal recovery, successful community integration, and satisfactory quality of life for persons who have mental illness or mental health concerns. PSR services and supports are collaborative, person-directed, they're individualized, and they're an essential component of the human services spectrum. They really focus on helping individuals develop skills and access to resources they need to increase their capacity to be successful and satisfied in living, working, learning, and social environments of their choice. Important phrase of their choice. And include a wide continuum of services and supports. I've stolen this definition from PSR RPS Canada, so thanks, Vicki, for that.
Sure. Just get closer to the mic.
How's that?
Yeah, stay close.
So, as I just mentioned a few minutes ago, PSR approaches are evidence-based, best and promising practices, and we're focusing on the key life domains of employment, education, leisure, wellness, and basic living skills. So there's a lot of literature, a lot of territory to cover. Also in the framework, we're going to be looking at family involvement, peer support, and peer delivered services, and again, you're going to hear some more of this later this afternoon with Debbie. So because of their demonstrated effectiveness and their recovery orientation, these approaches should be widely available, and this is an important phrase that's going to hear much more of in the next while. These are approaches which we believe should be available, I'm tempted to say must be available, to people who are living with long-term mental illness and or substance use problems. Very importantly, what's distinctive about PSR approaches, they build upon the strengths of people. We're not talking about building on people's deficits or weaknesses. We're talking about a strengths-based approach here. And we assess the person's strengths and we use that as the basis for individualized goal setting and recovery. So the whole process is really based on this important assessment of an individual's strengths. And in the next paragraph, what's really important there, if you look at the bolded print, is that PSR approaches involve the client, the person with lived experience, actually setting their goals rather than the goals being set by other people. And finally, PSR approaches support people to have a meaningful life. They focus on the determinants of good mental health. They include employment, education, social supports, basic living skills, leisure, and wellness. These are things that are really important to all of us in life. Another characteristic of PSR approaches is that there's a very different paradigm with PSR approaches. They generally place people in their chosen goal settings, such as jobs and housing, and then train and support them in those settings. This is a marked departure from the way things used to happen in the old days. In the old days, we used to prepare people for employment. We spent a great deal of time on pre-vocational training, things like that, so they could go out and be hopefully successful in their job in the community. That doesn't happen with evidence-based PSR approaches such as supportive employment. What you do is put people in the jobs to start with, and then you support them in those jobs. So it's a place and train approach rather than a train and place approach for employment. Same thing with housing. Instead of taking months and years to prepare people for living in the community, now we are using what we know is most effective as a housing first model. Put people in housing and support them in housing. Recovery is, of course, emerging as the dominant theme in mental health services these days throughout most of the country. In fact, the Mental Health Commission this is a key aspect of the national strategy to move the systems and services in this country towards recovery-based approaches. It's not a new concept. The concept of recovery has been around in physical rehab for many years. It's now very much emerging as the dominant approach in mental health services, and as well as substance use. It's starting to emerge as in substance use services as well. So recovery is generally seen as a personal journey rather than a set outcome, and one that may involve developing hope, a secure base and sense of self, supportive relationships, empowerment, social inclusion, coping skills, and meaning. And other names for this approach are recovery model or recovery-oriented practices. So we're, of course, all hearing much more about recovery, and it is really emerging as the dominant approach in Canada, as well as other parts of the world. Because PSR approaches are so effective and person-centered, these approaches are important tools to be used by individuals, families, and practitioners to support the individual in recovery. we really regard PSR as the royal road or the key tools for recovery for people. And from a systems point of view, apart from the importance for individuals, there are also some very important implications from a system point of view. Because the evidence is very clear that if you adopt these recovery-oriented PSR-based approaches, this results in very much reduced systems costs as well. And this is, of course, of great interest to administrators and policymakers because these result in reduced emergency admissions, reduced hospitalizations, less dependence on social assistance and law enforcement. And if you want to quantify this, and this has been done actually, there are quite substantial, I won't call them cost savings, but there's cost avoidance associated with the adoption of these approaches. So we're going to be focusing this morning on the evidence, and again, quite a bit of territory to cover, so I'm going to launch into this pretty quickly. We're going to be focusing on these domains this morning of employment, education, leisure, wellness, and basic living skills as sort of core PSR areas. There are some other areas that you might want to talk about this morning, such as ACT teams and things like that. But those are actually covered through the other advanced practices. So we're going to be focusing on these ones with framework as well as family and peer support. So we'll start off with employment, and thanks to Matt, who's done a superb job of taking my boring and dry presentation and adding some nice graphics and stuff in here. So thanks, Matt. So just as you start to go to sleep, you'll come up with some catchy kind of graphic here for you. So if work makes people living with mental illness sick, what do employment, poverty, and social isolation cause? Okay, we used to think that maybe work actually made people sick. Employment is very important, obviously, in the recovery of persons living with serious mental illness and substance use problems. In fact, employment is often cited as the most important need. If you do nothing else, give somebody a job, get some work. So there is a very, very large and significant literature base demonstrating the importance of work and supporting people to live successfully in communities. I'm not going to go through this evidence, and in fact, we didn't do this with the framework. I should have mentioned a bit earlier that we've just used the most the strongest evidence we can find since the year 2000. And we're talking about, for those of you who like technical things, we're talking about meta-analyses here, randomized controlled trials, Cochrane reviews, the real gold standard kind of evidence here for the most part. So, just one study, Bush, Drake, Z, Hugo, and Hazlitt 2009 study, a 10-year longitudinal study found greatly reduced hospital and service systems costs for individuals who were in stable job situations. This is a message that comes through repeatedly in this literature, that if you really want to cut down on your hospital costs, this is one of the most cost-effective ways to do it, is give people working, basically. So employment is tremendously important. So there's been a substantial change in approaches in the past 20 years to the employment of persons living with serious mental illness and substance use problems. Previously, as I mentioned a couple minutes ago, we emphasized things like pre-vocational training, preparing individuals for later employment when they were ready for employment. Current supported employment approaches do exactly the opposite and are based on first placing people in jobs and then training and coaching them in the actual job situation. So again, there's been this shift from a train and place approach to a place and train, or better, place and support approach. The main reason this has occurred is because of this large amount of evidence, very strong evidence, that supported employment approaches are much more effective in terms of the outcomes, particularly the outcome of successful employment. So, having said that, what about pre-vocational training? Is it something that we should completely abandon, or is there still some value in this? Well, pre-vocational training, of course, consists of this process of pre-employment and education support to develop and improve basic work habits, skills, behaviors of those people who are accessing services. They're aimed at preparing an individual for paid or unpaid employment, and the training typically involves work-related skills rather than training specific skills for a certain job, and might include such basic skills as improving attention span, motor skills, teaching job performance concepts such as attendance, you're more likely to get a job if you show up for it. Endurance, task completion, problem solving, safety, all of these kinds of things. Volunteer work actually is a way of providing pre-vocational training, and I'm going to be saying a bit more about that later on, but it actually is an approach to pre-vocational training where there is some evidence that it is in fact effective. And those of you in BC who are familiar with the therapeutic volunteer program know that that is a reasonably effective approach. So that is one type of pre-vocational training that really does seem to have some merit in terms of outcomes. Because of the dominance of supported employment, I have to say there isn't much current literature on pre-vocational training. It's kind of fallen off the map. However, there are some fairly recent. There's one fairly recent study of a pre-vocational training program by these investigators, Matt et al. In 2006, and this study reported the program to be helpful for individuals trying to re-enter the job market. However, the entry and completion rates for the program were low, with less than a third of the participants completing the program. So they judged it overall as being somewhat helpful, but as you can see for yourself, there were some real limitations to this approach. Say a little bit of a transitional employment. This involves placing people in job placements in the community, often on a time-limited basis, and job placements may include work crews. One type of transitional employment situation that some of you will be familiar with is what clubhouses do, and people are involved in clubhouse programs, and of course this is now accepted as a best practice, as quite a bit of evidence supporting clubhouse programs. And of course the original clubhouse, the Fountain House in New York, actually had these transitional employment programs. So there is some evidence that particularly at the clubhouse, suggests they're useful. This next slide gets into a bit more detail on that, if you can read at your leisure. It's just some background on Fountain House. What I wanted to move fairly quickly to is this type of supported employment, which is IPS. And IPS has really emerged as the dominant paradigm for supported employment. So virtually all of the literature that's coming out these days is on IPS, which stands for individual placement and support. It's, again, like other forms of supported employment, it's a place and train support model that supports individuals to find competitive employment based on their goals. And again, there's that key recovery concept of the person with lived experience setting the goals. As with other supported employment approaches, IPS emphasizes the initial placement in the work setting followed by support. And the effectiveness depends on the model being implemented with a high degree of fidelity. Fidelity is a concept we're going to be encountering a number of times this morning. Fidelity just means faith. The word itself means faithfulness. High fidelity means a high degree of faithfulness to the. This is not about fairs or anything. This is about the model. Fidelity to the model. So in this case, this is about IPS fidelity. So if you're asked to take a fidelity scale, don't worry about it. What I've done is provided a hyperlink here to probably the best used fidelity scale. This is one that's being developed by the Dartmouth Supported Employment Scale. This is not Dartmouth, Nova Scotia. This is Dartmouth, New Hampshire, and it's where you've got this powerhouse of investigators, including Bob Drake and Gary Bond, was there for a while, and all of the heavy hitters in terms of research in this area. All have been working out of there. So there's hyperlink for it, and I encourage you to, if you're involved with IPS programs, to have a look at that fidelity scale. Specific components of IPS, there's a focus on competitive employment. This is very important. We're not talking about people making widgets in a workshop. This is competitive employment we're talking about here. The eligibility is based on individual choice. Once again, there is an integration of rehab and mental health services, and so the programs are closely integrated with mental health services. There's and attention to personal preference, and there's personalized benefits counseling. You've got employment specialists who help clients obtain personalized, understandable, and accurate information about their about the benefits that they're going to receive in their job, as well as benefits they get from the government. We all know there's a bit of an issue with this in BC about clients working and getting benefits, but hopefully one of these days that will get resolved in a constructive way. Rapid job search is another characteristic of supported employment. Help clients obtain jobs directly rather than training them or doing lengthy pre-vocational assessments or pre-employment assessments. There's systematic job development. Employment specialists build an employer network based on the client's interests. So you've got the major function of the employment specialist is out there working with the with employers and developing settings where clients can work. And again, time unlimited and individualized support. We know from a great deal of evidence that often some people will need ongoing support. This isn't something you can necessarily just bridge. So those are the characteristics out of the evidence. Again, I could spend the whole morning talking about evidence for IPS, but let me just say that there's very, very substantial support for the effectiveness of this model, and I've given some review papers there as examples. I encourage you to look at these. Suffice to say, they all have consistently demonstrated better client employment outcomes in terms of job funding, tenure, earnings compared to clients and traditional approaches. Results are less conclusive in terms of other individual outcomes, such as reduced symptoms. So we can't argue that this is necessarily going to result in reduced symptoms and increased quality of life, but the evidence is very strong that you get better vocational outcomes. In addition, there's shown to be effective for people with concurrent disorders as well, and there's a reference to a study of user and Canadian research. We do have some Canadian research in this area. Eric Latimer out of, actually most of this group is out of Quebec. You can see Bob Drake's name in there as well from the Dartmouth group. And Myra Pitt, some of you will know, she's at Douglas in Montreal, does some Canadian research. Tanya Lecomte actually was out at UBC for a while and unfortunately went back to Quebec. She's a loss. They did this study compared individuals who were not currently employed and wished to work to receive IPS to those receiving traditional vocational rehab. So here's a Canadian study which does this. And again, the results demonstrate superior employment rates for those receiving IPS services, 48% compared to 18%. So you can see the order of magnitude here of the effectiveness of IPS compared to traditional approaches. And more hours worked, on an average 126 versus 71 hours per week. I guess I should mention the next one too, because it's got a couple of local names in it: Oldman, Thompson, Calcivari, Luke, and Bond. That's Gary Bond, who's actually working with the Vancouver group here. And they actually published a paper on the results of transforming sheltered workshop program to an IPS model. And while the sheltered employment program was in operation, fewer than 5% of participants achieved competitive employment annually, but IPS, 50% of the participants achieved competitive employment. So just very dramatic results through transforming that program. Okay, take a deep breath, me especially. Again, apologize for going through this at breakneck speed, but it's the only way we're going to get through this morning. Sweet lady over there tells me she's got all sorts of nasty messages sent my way if we don't finish. Education is not the throwing of the pail, but the lighting of the fire. But the days. Something from the Irish for Regina. Education, supported education. There is less literature in the area of supported education, but it's still important literature, I think, and we'll find some BC references in this one as well. Supported education refers to services and supports which assist persons living with mental illness and or substance use problems in achieving their educational goals. So now we're talking about education. The core components of supported education include career planning, academic survival, skill building, and connection to academic and mental health substance use supports and services. They're recognized as exemplary practices which contribute significantly to the academic success, resilience, and recovery for persons living with serious mental illness. Probably the milestone here, an exception to the 2000 literature, is the publication of a handbook of supported education by Karen Unger. It came out in 1998, so many of you will know of this, which stimulated particular interest in research in the supported education approach. So since that time, there's been a significant amount of literature which has been published in this area, which usually involves post-secondary education programs, like Douglas, for example, as a supported education program. And I think you're going to be seeing more and more in the next while in terms of this actually moving downwards into secondary education, high school programs, and perhaps even earlier. Evidence, major review, Mowbray et al., 2005. This is an American study, documented the evolution of the supported education model as well as the evidence for its effectiveness. And this is a good review paper to read. It again shows that you get sufficient evidence of effectiveness to make this a best practice. The evidence usually is in terms of increased course completion and greater likelihood of re-enrollment in the following academic year. What are your indicators? Do people actually sign up for courses? Do you get an increase in this, and do they continue with their education program, or do they drop out? And hopefully with the supported education program, you'll reduce dropout, and that's what the evidence shows. There's a Rayleigh study, Rudnick and Gover, 2009, evaluated the effectiveness of combining supported education with supported employment. So what happens if you take the two approaches and put them together? And they found that they got some encouraging results with this, and recommended further research in this area. I'm mentioning this study for a couple of reasons. One is that we're fortunate enough to have Rami Rudnick, who's a psychiatrist who's really been a PSR champion. He was actually on our PSR Canada board for a while. He's now the regional psychiatrist for Vancouver Island Health Authority, is the new name for them. So we're delighted to have him over in Victoria, and he's shaking and moving things over there, and we're going to see a strong PSR focus emerging over on Vancouver Island, thanks to Randy. So it's the same guy, and he did this study with Gover back in 2009. He's also got a grant application in right now to do a major study in BC. And I know that because I'm one of the co-applicants on this grant, and we're hopeful we're going to get funding for this thing. And we'll have a BC-based study which will involve Douglas, Camosun, and Gastown Vocational Services downtown. Leisure. So we're into another domain here. This is the domain of leisure, and here's another quote, thanks to Matt. The word recreation is really a very beautiful word. It's defined in the dictionary as the process of giving new life to something, of refreshing something, or restoring something. So this something, of course, is the whole person. Good quote there, Matt.
Yeah.
Supported leisure. Not much literature in this area. It's one of the small areas, but leisure again is, I think we all, as all of us who are in the PSR world, understand the importance of leisure. And supported leisure services assist individuals living with serious mental illness, substance use problems to access and enjoy community leisure resources and activities. Supported leisure recognizes the importance of enjoyable leisure activities poor quality of life and recovery. Leisure is a very important part of all of our lives. These services are also important in building social and leisure skills as well as social networks. Evidence. We can go through this pretty quickly because there isn't much. Again, this is evidence since 2000. A study by Davidson et al. Conducted a randomized controlled trial of the effects of a supported leisure program. In 2 of the conditions, participants were assigned to volunteer partners who facilitated their engagement in recreational activities. And all the participants were found to improve in terms of reduced symptoms, better self-esteem, and overall functioning, particularly for individuals who had more contact with their volunteer partners. Another study by Lloyd et al. 2007 studied the association between assessed motivation to engage in leisure activities and the self-reported perception of recovery in a sample of 44 clubhouse members. Again, there was a modest but significant relationship found. So this, just to summarize on leisure, and again, as we said, it's quite a short area, but just to summarize, this is really in the nature of a promising practice. We don't have a huge amount of literature. We've got the one randomized controlled trial, but it's more in the area of promising practice right now. Basic living skills. Setting goals is the first step in turning the invisible into the visible. So what are we talking about here? Okay, well, what's this thing? What are basic living skills, and what's skills training all about? Well, mental illness and substance use problems can lead to people having difficulties in such basic living skills as personal hygiene, home cleaning, managing money, shopping, using transportation, ensuring personal safety, conversing, making friends, living independently. What life skills programs attempt to do is to teach these basic skills and thereby increase the success and quality of community living. And programs may include teaching and supporting a wide range of activities of daily living. There's a famous term, ADL. Those of us who have ever worked in hospitals are familiar with. And social skills such as maintaining personal hygiene, appropriate dress, using transportation, shopping, managing a home, planning, managing time and finances. Strengthening social skills, developing healthy eating habits. And teenagers could benefit from these programs. Adults too. Taking medications, navigating and accessing community services. Some programs also include matters relating to planning for personal safety, such as understanding potential fire safety issues. Big issue right now in Canada, of course, unfortunately. Coping with the pressures to use substances and learning ways to avoid victimization by others. There's a substantial amount of literature on teaching basic living skills, and a major contribution to this literature has been, probably the leading contributor in the world, has been Dr. Robert Lieberman and his colleagues at UCLA. They've had a very long standing research program there on teaching basic living skills to persons with serious mental illness. And there are a large number of publications that are available online. I've put a link in there for that's actually Lieberman and his colleagues have their own website. And if you are interested in this area, please have a look at this. Lieberman has really been the leader, and his colleagues have really been leaders in this work. They produced a large number of articles and books describing basic living skills, teaching approaches, and training modules. So they've actually got, they really emphasized on developing training materials. I don't like the word training, but that's what they call them. So I had to put it in here. They've done them in the areas of medication management, how do you properly take medications, symptom management, how to manage your symptoms. We'll take a look at this more in a few minutes when we look at wellness. Recreation, basic conversation skills, community reentry, workplace fundamentals, substance use management, and friendship and intimacy. So they even get into areas like, if you've ever seen any of Lieberman's tapes, if you haven't seen them, I encourage you to have a look at these. They're quite interesting. He gets right behind his the people he's working with, and he actually coaches them, and he teaches them how to ask for a date, for example. It's one of the better ones to look at. Say this, and actually coaches them through the whole process, how he asks somebody out for a date. So he really focuses on all the really important areas of life, which fit into things like friendships and things like that. So I encourage you to look at that work. So they published a large number of studies demonstrating techniques for teaching basic living skills. Got some review papers up there you can look at. Hertz and Muser conducted a meta-analysis of the Lieberman Group's social skills training interventions. Looked at the effect size of social skills training on client outcomes, and they found a strong positive effect on mastery of social skills, activities of daily living, role performance, community functioning, and negative symptoms. That's reducing negative symptoms, not increasing them. With only a small effect on other symptoms and relapse risk. So they concluded that social skills training of the Lieberman type, at least, if you follow his curriculum, helps people with serious mental illness perform the activities of daily living and improves general community functioning, and should be provided as a component of a comprehensive psychosocial rehab approach. However, and there's the big however here, other research findings really question the value of these training programs. For example, Cochrane Review, which I think everybody knows is a major review of randomized controlled trials, so they're sort of the gold standard. Here's one, I won't try to pronounce this guy's name, but this review came out in 2011 and compared the effectiveness of life skills training, the standard care and support groups, and no significant differences are found on social performance, quality of life, or symptomatology. So, similarly, another study by Gibson et al. In 2011 concluded that while training can improve social skills and life skills, it does not lead to improvements in overall role functioning. So the suggested social and life skills training may be a useful adjunct, but it is of limited value in itself. Okay, I'm going to get into how are we going to time? Okay. Half hour. Okay. This is a major area that we're going to get into now, which is an area of importance to all of us, which is wellness. And here's our World Health Organization quote here. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So this is what we're looking for. We're looking for health in the World Health Organization's this broad sense of persons' mental and social well-being, and not just absence of disease. Wellness is a term that's used a lot. It's thrown around. And we hear about wellness programs, but what does it actually mean? And if you actually start digging into the literature on wellness, you'll rapidly become frustrated with the myriad definitions of wellness that are out there. And there doesn't seem to be a lot of agreement, but there are some common themes which emerge. So another way of saying that is a commonly used but complex, multi-dimensional concept which has many different definitions. Sounds like a psychologist wrote this. Among these definitions, there is, however, general agreement that wellness refers to a desired state of physical, mental, and spiritual well-being. And I want to emphasize spiritual because this is now being considered as really important for wellness. Therefore, it is not the same as absence of disease. It also involves making lifestyle choices. So here we're going back to that fundamental concept in recovery of choice. Accordingly, lifestyle modification may be necessary for people to achieve wellness. So what if people don't make good choices? Already people should be able to make choices to say they don't make good choices. Many of us don't always make good choices in life. That means we may have to get into lifestyle modification. So wellness may require us to stop some things which are not so good, like smoking or drinking too much or risky lifestyles. So while lifestyle is an important determinant of wellness, it must be recognized many people with mental health substance use problems cannot achieve wellness simply through modifying their lifestyle. So it's not enough just to say to people, hey, start living a clean life and you're going to be okay. Often the lifestyle is affected by the symptoms, which may include such things as we all know as a lack of motivation or a lack of interest in everyday activities or relationships. Just don't want those things. Accordingly, achieving wellness will involve addressing their mental illness and or substance use problems in addition to looking at lifestyle modification. So lifestyle modification itself is not what we're talking about here. There's also well known to be a very significant relationship between physical illness and mental illness, and I just wanted to say a little bit about this. So compared to the general population, persons living with serious mental illness, substance use problems, concurrent disorders have a higher incidence of physical illnesses, which are often related to things like medication side effects and lifestyle factors such as lack of exercise, obesity, and smoking. On average, people with severe mental illness die 10 to 15 years earlier than the general population. This is partly due to suicide and accidental death, but the rates of cardiovascular disease, including heart attacks, diabetes, respiratory diseases, these kind of chronic diseases, are as much as 60% higher in persons living with serious mental illness. There's a reference to that if you're interested in this literature. It's quite strong literature showing this very high correlation between physical illness and mental illness. These high rates of serious physical illness have led to a significant amount of research on how behavior, which is risky to health, may be altered. Accordingly, in the review of the lifestyle modification literature for persons with serious mental illness, there's a review of Richardson et al. 2005, and reported dramatic reductions in chronic disease rates in the order of 60% through increased physical activity. So if you just increase physical activity, it will have quite a significant reduction, if I can use medical terms, in morbidity and mortality, illness, in other words. This is one of the other hats I wear. Is I'm on the board for the Chronic Disease Prevention Alliance of Canada, and this is they really they're quite concerned about this very high relationship between mental illness and physical illness, and are really building this into their campaigns to improve wellness. So let's look at some individual issues in this area. Healthy eating and active living. Okay. There's a substantial literature which documents the beneficial effects of exercise for persons living with mental illness. For example, is papers by Korchinski and Faulkner in 2011. It's a review paper, reviewed the health benefits of exercise for people with schizophrenia. And the health benefits of exercise were found to be significant. The review concluded that regular exercise programs for persons living with serious mental illness can have very beneficial effects in terms of better physical and mental health. The same investigators also reviewed weight management programs for persons living with, some of the same investigators living with serious mental illness, and found that both CBT, cognitive behavior therapy, which I'll talk about in a bit, and pharmacological adjunct therapies were effective in preventing weight gain. This review also found that CBT was effective in helping people lose weight. So this research has got important implications since preventing weight gain is an important factor in preventing diabetes, stroke, and other heart disease, other chronic disease. Smoking, big issue. Smoking remains a major public health problem in Canada and other countries. So there's been major worldwide research on effective ways to stop people from smoking. Meta-analytic reviews suggest individual behavior counseling and motivational interviewing techniques may have some value in assisting people to quit smoking. I'll say a bit more about motivational interviewing in a few minutes. Cochrane review, bupropion, which is a medication, increases smoking abstinence rates as well as increasing the rate of smoking in persons with schizophrenia. But the authors failed to find convincing evidence that other interventions are useful in reducing or stopping smoking in people with schizophrenia. So there is some evidence showing that this is an effective pharmacologic agent in smoking cessation programs. System and medication management. Huge issue because we know that many people with lived experience stop taking their medications because of the undesirable side effects. And PSR is not an anti-medication approach. We recognize that many people require medication, and so we've had a look at this literature as well. And the first study shows that multiple education sessions delivered at frequent intervals are more effective in improving knowledge relating to medication and insight to illness. It improves the likelihood that people will continue to take their medications. Cochrane's review of this area aims at all examined interventions for various health conditions, including serious mental illness, and included that interventions that enhanced adherence were generally complex and included multiple, I'll sort of cut to what really seemed to be effective. Giving people telephone reminders, so actually situations where you actually phone up people and remind them to take their medications are often the effective approaches, but overall the effectiveness was modest. Real meaning saying that you don't get a really strong effectiveness, but it's better than nothing. Metabolic syndrome, people living with serious mental illness are increased risk for metabolic syndrome, including insulin resistance, high blood pressure, and increased risk for clotting, and it's associated in turn with higher risk of cardiovascular disease, diabetes, and stroke. And again, so the issue here is reducing obesity. And the study by Tirupati and Chua, a study in New Zealand, found the prevalence of obesity to be 2 to 3 times that in the general population, and many of the individuals were not being active. This is really what the punchline is here. Many of the people were not being actively treated for obesity and metabolic syndrome. And so these investigators recommend the active treatment of both to reduce morbidity, mortality, and improve rehab outcomes. Illness management and recovery approaches and relapse prevention. Okay, this is really probably the most important thing I'm going to say here today in terms of wellness. There is a very large literature on this area. How do we stop relapse prevention? In other words, how do we keep people from relapsing and ending up back in hospital again? And there's, I just wanted to say, without getting into huge detail on this, there's a very substantial literature in this area. In fact, the Americans have developed a whole best practice areas in this being developed by user and the investigators you see here. They've reviewed services which facilitate recovery through assisting individuals to understand, manage, and mitigate the effects of their mental illness. One of the important services is psychoeducation, which, terrible term, I don't like it either, but psychoeducation helps individuals and their families learn more about their condition. Behavioral tailoring, which helps individuals take medications as prescribed from daily routine relapse prevention. Teaching people the warning signs, prodrome warning signs that they're starting to have problems and it's time to call their mental health center or their psychiatrist or team member, whatever. And also teaching people CBT to manage their symptoms of stress. Why not teach people how to use CBT on themselves so they can actually manage their own symptoms of stress? So, user et al. In these reviews have found that these approaches are generally not being implemented the way they should be, and if we did implement these illness management and recovery approaches, we would greatly reduce the degree of relapse and hospital readmission. So this is a tremendously important area that I think that we really need to start building into the way we practice in mental health centers and hospitals and any other setting where we're providing services. Just a tremendously important area. One specific type of illness management and recovery program is this one that many of you are familiar with. It's called RAP, Wellness Recovery and Management Approaches, and it's been developed by Mary Ellen Copeland, and it's a self-management approach. So this is the best kind of approach where you again teach people to manage their own illness, and put a link there to Mary Ellen Copeland's website. Many of you know about RAP, but it now emphasizes a wellness and recovery action plan, which includes coping skills to remain well and avoid relapse. And peer modeling and learning are important aspects of RAP. There's quite a bit of research done on RAP, including research by Judith Cook, who many of you will have heard at the last PSR conference in Vancouver. And again, the research suggests that peer-facilitated self-management training is effective in reducing symptoms while increasing hopefulness and quality of life. RAP is really catching on quite a bit. Canadian study here is done by Warwick Krupa and Armstrong. Krupa is our really beloved Terry Krupa from Queens, who's actually Vicky's board chair, and she's professor of OT at the Queen's, and this is an example of hers, one of her studies, which she's had a whole research program on recovery and got similar positive results. So I recommend that to you. Concurrent disorders, many people, of course, have concurrent disorders. There's some literature in this area by people like Ken Minkoff, Muser, and Drake. And basically, all I'm going to say about this is that the literature suggests that integrated approaches, integrated mental health and substance use services are the best approach, and that's what we should be doing. And that's, of course, the strong message that the Minkoff gives. There is no such thing as a closed door. All doors are open. It doesn't matter if you go into the mental health center or if you go into the substance use treatment center. You get the services you require, and all staff are trained to do all of them. So that's basically what the literature supports. I wanted to.
Closer to the mic.
Sorry, how much time we got? Okay. So we can actually get through this. I wanted to spend some time on this next topic area, which is, to me, a tremendously important area and one which doesn't get nearly enough attention. So I'm going to get into this in a bit of detail. This is what happens when you combine PSR with other clinical approaches. And we call these other clinical approaches, they go by a number of names, but I'm going to call them enhancing clinical tools and techniques. These are evidence-based practices which improve the functional abilities of clients, particularly cognitive functioning, and or reduce the symptoms and deficits associated with severe mental illness and substance use problems. These tools and techniques can significantly improve the outcomes for people in psychosocial rehab services and programs. The first thing we're going to look at is cognitive remediation. What is cognitive remediation? Well, basically, cognitive remediation it actually came out of the neuropsychology world, and it was a technique which was originally developed to work with people with brain injury who had cognitive problems, and basically taught them skills to compensate for some of the cognitive difficulties, and they might have memory problems and attentional problems and other kinds of cognitive issues. So what this literature does is it combines those techniques with PSR approaches. And there's actually quite a substantial literature emerging on this. And second paragraph there, for example, to examine the effects of combined cognitive remediation and vocational rehab in persons with concurrent disorders, a randomized controlled trial was conducted by McGurk, Muser et al., 2009. The people who received the combination of cognitive rehab and vocational rehab improved the most on cognitive as well as vocational measures. So, just to tell you who some of these people are, McGurk is Tim Muser's wife. She's a psychologist, Susan McGurk, and she's done most of the pioneer research on using cognitive remediation with other PSR approaches. So that's why you see her name here. Muser, of course, whose name you've seen many times already this morning, is a very distinguished PSR researcher who is now moved over to, he was at Dartmouth with Drake and that bunch. He's now moved over to Boston. He's taken over Bill Anthony's job at Bill Anthony retired, and Tim Muser now heads up the Boston psychiatric rehab program. CBT, cognitive behavior therapy, is a generic term which is applied to an increasing number of therapies which are usually directed at reducing positive symptoms of psychosis, such as hallucinations and delusions. There's a growing literature which documents the effect of these therapies. Gould, Muser, Bolton, Mays, Goff, 2001, conducted a meta-analysis. 17 treatment outcome studies of cognitive therapy for psychotic symptoms in schizophrenia, and suggested that CBT is a promising behavioral strategy for decreasing the severity of delusions and hallucinations, or helping clients to cope with these symptoms. Motivational interviewing. This is something we're hearing more and more about, of course, particularly in the substance use world. There's quite substantial literature in the application of motivational interviewing techniques, particularly in the treatment of substance use problems, which have actually evolved from Rogerian client-centered therapy, for those of you who remember that. way back when. Motivational interviewing techniques have evolved from that therapy, and it's defined as a collaborative form of personal therapy which is intended to enable, facilitate, and strengthen an individual's motivation to change. Meta-analyses conducted by Burke et al. And a Cochrane review by Smithland et al. All document the effectiveness of motivational interviewing in affecting positive behavior change in clients with alcohol and other substance use problems. Family involvement and support. Again, we're recognizing the importance of family. This is tremendously important. We talked about this a bit before. Family is defined as anyone in the support network of the person with mental illness or substance use problems. We're not just talking about traditional North American families. We're maybe talking about partners, siblings, offspring, as well as friends of the individual. It's the family as defined by the individual with lived experience. Families have needs as well, and families are very important in the recovery of people, and so we're recognizing this. I mentioned family and psychoeducation before, and there's a very substantial literature on the very beneficial effects of working with families and helping them to understand the mental illness and substance use, and frankly, reducing the amount of stress in the family unit. And that is a significant factor in reducing relapse. And again, this is not new literature. This is literature that's been back since the 1970s, actually. So we've got a pyramid model, which we're using which will appear in the framework and will be in the slides, and it just really shows the importance of building on family involvement, including perhaps at the top actually moving from connection and assessment all the way up to providing family therapy. Family psychoeducation, again, here's some references to this literature, very, very large literature here. And as I mentioned before, the early work was done by Dr. Ian Falloon, actually, and his colleagues. And a major goal of this is actually to reduce what Falloon originally called EE, which basically means screaming and yelling at going on in the family. And they basically call it expressed emotion. So next time you get in a fight with your people in your family, it's all about EE. Again, meta-analysis shows, and there's a large amount of literature in this area, that if you can reduce the amount of stress in the family, particularly through psychoeducational approaches, it has a huge payoff in terms of reducing relapse and emergency admissions. So it's something we need to be doing routinely. Peer support, again, you're going to hear more about this later today, but we've seen in the past tremendous interest in peer support, and there's a really rapidly developing literature showing the effectiveness of peer support. And lived experience is no longer a barrier, but is now an asset to providing peer support, obviously. So we're recognizing the importance of peer support, peer delivered services, and they are now considered the core services which should be available to all people who can benefit from them. And here's some references to the literature. A recent survey of literature commissioned by the Mental Health Commission of Canada, 2010, concluded that people with lived experience can offer major benefits to each other through developing personal resources and healing themselves. Not only does peer support improve the quality of life, it also significantly reduces symptoms, reduces hospitalization, reduces mental health, medical and social services. So when you have to make a case to fight for peer support services, you can tell your administrators and policymakers and decision makers in the system, hey, look, this actually does reduce systems costs. And I think that's an important message we have to be able to give, especially in these days of shrinking threatened budgets. So that's it. I've included a large number of references as part of the slide deck, and so you can get them off the. They'll be on the web, part of the webinar slide deck, and they'll also be available to you on the advanced practice website, and we have to make sure we give everybody the URL.
And they're there now.
They're up and running right now, so thanks for that, Matt. And you can access those and read about all the stuff that you got board listening to me say this morning. So thank you.
So thanks very much, John, for a fantastic presentation about so many important areas. So this is for the webinar folks. Again, thanks, John, for a fantastic presentation on some really important areas of practice. Just to mention a few, John talked about supported education, supported employment, IPS, leisure, basic living skills, peer support, family, CBT, motivational interviewing, RAP. And it was so great that you were able to bring the research alive with your anecdotes of some of the researchers that you know about. So thanks for that. I've read those papers, some of them, but didn't know about some of those researchers. And on a personal note, and just to speak about John in terms of how he was talking about, we can talk to our administrators about this evidence and we can create change. And I've been lucky where I work on the North Shore to be part of some change. A year ago, we didn't have supported employment. We didn't have the IPS model, but through my team, we were able to talk to our managers, show them the evidence, and reconfigure our team to include an IPS worker. And I've been fortunate enough to be working in that role for the last year, and it's been really exciting to see people getting work and actually live some of this evidence. So I encourage you to talk to your administrators, and we can make change happen where we work. So thanks again, John. We're going to have a break now for the next 15 minutes. We'll reconvene here at 10:45. It's playing tricks on me, Matt. And there's coffee and tea available in the main foyer. So we'll see you back here at 10:45.
So again, just for the benefit of everybody on the web, if you could just sort of make your way into the room a little bit more quietly, because obviously everything's getting picked up and it's difficult to hear the presenter speak while everybody's still chatting a bit. So come on in, grab a seat, but we got a nice long break at lunch and there's tons of more networking opportunities coming up. Jennifer says now it's very loud. What can you get going? Okay, well I can back off.
Way too much volume.
right, folks. I'm gonna beg you now. I'm in my basement. Yeah, excellent. Thank you very much. Okay, so welcome back to the next session. This session is on the PSR advanced practice. What is that, you ask? Well, I'm going to tell you this one. And in the context of this advanced practice, we're talking about our community of practice, which is, of course, everyone in this room and beyond, everybody online and around the province. So we have some very, very special guests with us today, and I'll be introducing them shortly before we get into the conversation about our panel. But first off, what is the PSR advanced practice? In its most basic form, the PSR advanced practice is a partner project currently funded by the Ministry of Health. Thank you very much, Chris, Garrett, etc. And in partnership with Douglas College. And so again, once again, thank you to John for doing the tireless work that it takes to apply for these grants and contracts to make things like this happen so that we can, again, move forward with PSR in the province. The purpose of the PSR advanced practice, of course, is to support clinicians and managers responsible for providing PSR services. This is its contracted mandate. The PSR AP supports the field in very different ways. This is stuff that we're working on right now. The advanced practice has sort of been in inception for about a year and a bit. And it's informed by a provincial advisory committee on PSR. Many of the members of that committee are here now and online with us. And it serves several roles, of course. One of the most influential roles is the transferring of evidence-based knowledge to the field. That is going to come in the forms of things like today's event. And of course, it's also going to come in the form of the PSR service framework. So this is a provincial document that's nearing completion. Nearing completion. That covers all the information that John presented this morning, plus a whole ream of additional stuff, practice guidelines, optimum continuum of PSR approaches across the spectrum of services. So we're talking about primary care, secondary, acute and community care, tertiary care. So all these settings were PSRs identified to be applicable. We have sort of guidelines that have been drawn out through the evidence, as well as an entire second section, which is an environmental scan. So the province was polled, and discussions and interviews were held with key stakeholders and players in each of the health authorities around the province as to what kinds of PSR services were currently available across the domains and in the different areas of the spectrum. So that information is all included in there in a condensed presented format as well as individual appendices for the different health authorities. The PSR AP also provides expert clinical consultation to the field, develops and presents training and education events such as this one and future events as well. We're going to be having webinars from now on. I mean, of course, this is partnership with PSR BC for their annual provincial conference. But from now on, we're trying to do about 10 a year, so one almost every month on a different topic that is going to be available again to everybody around the province via the web. Different websites and resources. So we have an advanced practice website that I will give everybody the information to at the end of the day. It's quite easy. It's psyrehab.ca, psyrehab.ca. It's got videos, it's got files, it's got links to appropriate information, as well as going to be the source for registering for the online webinars. As well, the potential to do specific project management roles as with the PSR advanced practice provincial advisory committee. What is the community of practice now? So the community of practice, as I mentioned, of course, is you. It's made up of all the individuals who have a professional and personal stake in the growth of PSR services in the province. And so just a few of the examples that we came up with were clinicians, managers, and coordinators. Very important that it exists at every single level of the services, as well as people who access services and family members, key stakeholders, nobody who is more of a key stakeholder, of course. Educators, also super important. So we're in the works right now trying to link to the different professional schools and associations that are supporting individuals who come up and then work in mental health and substance use settings to implement best practices and evidence-based PSR. PSR practitioners who are already currently in the field and who are coming up, community agencies and policymakers as well. So from top, bottom, and back again, we're hoping. Here's the panel. So we're going to move into a panel discussion format. Essentially, we've got some guiding questions, a few guiding questions. I'm going to pose the questions to each panelist. People can answer as they feel. And then we're going to throw it to the audience. Of course, that means audience in the room and audience on the web. And I'm going to try my very best to monitor the audience from the web questions and then pose those back to the panelists and everybody in the room. So as you have a question, just indicate, and myself or Jill are going to identify that and then pass you the mic so you can ask that question. And again, just for the benefit of everybody online, if you can speak as closely to the mic as possible. So you're down. To my right and to your right is Dr. John Higginbottom, who is the Associate Dean at Douglas College here. He's the Project Manager for the PSR AP. He's the Clinical Associate Professor in Psychiatry at UBC. He's the former Chair of PSR BC. Several other things, I'm sure. Superhero, yes, exactly. So he's essentially, if you want to know who's making all this happen, from the crux of it is John. To his right is Stephen Epp. Stephen Epp is an occupational therapist in Vancouver Coastal Health. He's also an instructor with the PSR diploma program here at Douglas. Dr. Natasha Absal, who is a rehab psychiatrist, a rehab specialist psychiatrist who is working in Fraser Health. First time I ever heard of this rehab psychiatrist specialty, and it got me very excited, so we knew we had to have her in her event. Thank you. Vicki Heen, to her right. Vicki is the chair of PSR Canada. PSR RPS Canada is with us right now. So this is a monumental day, and she's also live tweeting this event. So I don't know if you guys are on Twitter, but follow Vicki and see what's up. There you go. To her right is Dr. Regina Casey. Regina is also an occupational therapist in Vancouver Coastal Health as well. Also works as an instructor with the Douglas College PSR diploma program. She is currently one of our co-chairs of PSR BC and is linking into the PSR advanced practice to develop the webinars and the training materials as well that you're going to be seeing in the coming year. So we're going to get started. Everyone on the web, yes, I will type out the names of the panelists. First question. I'm going to pose these questions, and if you feel like you have an answer, maybe just jump in. Once again, the request speak as clearly and close to the mic as possible. First question that we have today is, how can we best make PSR services and programs available to persons with serious mental illness and or substance use problems in BC? How can we make these services available, and what would be an effective strategy to engage with the health authorities?
Who's up first?
I did give these questions to you in advance.
I was worried that I would be talking too much, so I thought I would
Exactly.
wait till second. So, is that okay?
Please first.
All right. See, okay.
Yeah.
So, first of all, when I read the question, for me, PSR is broader than services and programs. So part of me is to start looking at the journey of people with severe persistent mental illness in the province and all of the people that they interface with, including their families, their neighbors, their citizens. So it's broader than services and programs. And that's also where I see the resource. I see this advanced practice community. It keeps cutting in and out. The AP community of practice is one vehicle to upskill a certain group, the healthcare professionals, but I think we also have a role in upskilling our citizens, upskilling our bankers, upskilling our neighbors, and upskilling our family members. And that's what this is it's going to raise the bar. The journey hasn't been good enough, and that's what this bar is saying. It's saying we have tools, we have techniques, we have evidence. It's sort of cutting it out.
Yeah, we're just using the wireless one. Just patch it.
So basically raising the bar. And I see that's the thing. We're going to need to define things broader, I feel, in my role. When I decided to join the panel, I thought I would speak from the perspective of being an instructor with the college here, being a clinical lead within Vancouver Coastal Health, but also as a citizen. And so some of these things have roles for me with my family, for my friends, in my role outside of 9 to 5. So that's how I see gaining access. I don't see it in more resources in any one sector. I see it as rallying the resources we have. And by and large, at least from all people that I've met, our values, our heart, our soul is in the right place. Now it's a matter of linking everything together. So that's where I would start.
Kind of following on from what Steve was saying, I think a lot of the work is already being done. Especially talking in relation to what we do in the community, A lot of our programs are now shifting to the community. We have a lot of consumer-led programs. I think what we just need to do is, because services are so fragmented, and because this is a new concept, I think we need to educate and train our staff, I think, more than anything, so that there is a wide acceptance and understanding of what we're actually trying to do. And I think till we do that, I think, it is going to be challenging. And I'm actually quite pleased. And I think the idea I came with today was, okay, if there's one big thing that I want to convey is, I'm kind of new to Canada, so I struggle trying to find resources. So I'm still on that learning journey, finding out what's available, what's not, what's in development. And I think that website is the one message I had literally come here with. I thought, okay, you know what, we need to have one platform where people can go. We're talking about staff, we're talking about consumers, we're talking about families, where the resources are there for educating as well as for, finding out what events, what's new, so I think it's a good start. I think it's a brilliant idea. So yeah, the work is already being done. Really, it's very fragmented. It's really streamlining the whole process. I think that's what we need to do.
I think there's some serious tweeting going on here. Well, I looked at this question and I think, oh my word, that's a little overwhelming. I think what we have is a platform through the framework document to help us articulate and to help us understand some of the gaps, I think, in the literature. I mentioned that to see people receiving services in the audience today is thrilling. I really do think that a way forward is for people receiving services and family members to understand the potential of services, to advocate for them, to ask for them, and to expect them. And I'm not sure we're there yet. I think that as somebody who works in an organization, Vancouver Coastal Health, sometimes it's hard to affect the change you want to see. It truly is. It's hard to, you have a dream of being able to develop some services, and you have supportive people around you who help you, but to really get high-level service that's consistent, that's accessible, that's meaningful to people, I think we need people receiving services and family members to be able to articulate that too. So it's probably building a little bit on what Stephen is saying, and he broadens it into sort of the notion of citizenship and participation. In other words, to help educate citizens, such as bankers, to help people participate. I also think that just really helping people receiving services and family members to understand what they can contribute to our communities, to understand how they can help us be better human beings. There's a researcher in the US who talks about building skill banks, helping people articulate what they have to offer, helping communities understand what they need, and matching those people. So I concur with the idea that having a platform where we can communicate, where we can develop ideas. I have this dream that we should be able to do some extremely good research, and that is part of my dream within that context, but where we can just really advance Canadian practice. I'm going to say one more thing and then I'm going to hand over the mic. I'm really delighted to see so many students here today. So I know that we have a host of occupational therapy students who, and I thank you, who have agreed to do a lot of volunteer work for us by manning rooms and supporting rooms. And I know we have a lot of PSR students here from Douglas College. So a shout out to Douglas College for taking on PSR training and support. And a shout out to the students who are here today and who are also keen to further their education with online programs. A big thanks to Douglas College for situating and taking time to make this learning available. So I agree, we're on the journey, but we have some work to do, I think.
We actually just have a couple comments from online. Sunil Mathur is pointing out conversations about revolving door phenomena. So using PSR services as a preventative measure, and specifically in follow-up from inpatient settings. So when a hospital intervention has been employed, that folks aren't lost after they're gone, right? So that the work continues outside that door to make sure that it doesn't happen again as much as possible. Any other comments on that one, John?
I just wanted to add a little bit to the discussion about how you affect change out there. And this is something the Americans have had more experience with than us, and if I can go back into evidence-based stuff just briefly, they convened a conference back in 1995, and they were grappling with exactly the same problems we're talking about here right now. How do you actually transform the way things happen in the community? And so they had this conference that was actually funded by the Robert Woods Johnson Foundation, which is Johnson & Johnson Advantage, meaning they got lots of money. And they pulled together a brain trust of some of the major thinkers, people like Derek Vaughan and Drake and all some of the people we were talking about earlier, and got them in the same room, and they basically worked out a national strategy. And what they thought needed to be done, and I strongly believe in this, is you have to develop educational materials for all of the stakeholders that are out there, for families, for people with lived experience. You have to have it for practitioners. You have to have it for administrators, for policymakers, decision makers, and that's basically what they did. They developed these things called toolkits, and they consisted of video materials and all the kind of stuff that we're doing this morning. And their strategy was to really target everybody. And if you can make everybody aware of the benefits of doing this, then maybe you can really get people to buy into this and insist that these services be made available. If for example, if there's a new cancer treatment comes out, everybody knows about it right away, and people demand that they receive it, or a new MS treatment or whatever. But if we've got effective evidence-based mental health and substance use interventions, and if we can make people aware of these and push for them and want to choose these things, and everybody's aware of that, then it's much more likely that you're going to get that kind of system change. So.
Awesome, thank you. So part of this process is about engaging with our community of practice, and this community of practice is sort of our hub, our first contact is in the room right now. Does anybody out there have any ideas related to this question specifically, either online or in the room? Any thoughts about engagement? Yeah, absolutely, thank you.
I'm an employment specialist.
Sorry, can you hang on for 2 seconds just so we can have the mic so that everyone online can hear you? Sorry. Normally it wouldn't be. Okay.
Hi. My name is Jane Boyer, and I'm with UB Society as a vocational employment specialist. And one of the things that I believe we need to do is to really break down stigma of people with mental health. And I believe that it's each and every one of us in this room have a responsibility to do that. And the best way that they can do that is to be not afraid to talk about mental illness and substance abuse to everybody, and to also share their knowledge and their expertise. And I think sometimes we underestimate the power that we actually have as individuals to do that. So yes, I think it's good that they have toolkits, but I think it's also important to let people know that those toolkits exist. That's really what I just wanted to say. I think we all do that in this room. So if everyone in this room, spreads the message, that's really important. Okay?
One of the key things, I think both in PSR and from my sort of practice-based wisdom is having the right message from the right person at the right time. And that's what I think you're speaking to, is really looking at all the different resources and having all of us have a role in this, and not limiting people based on their labels, but seeing all of us as having an impactful role. If I go and speak to a community forum about the need for a new housing project in my neighborhood, people may not listen. If I bring somebody who's going to be living in that new housing project, people start to listen. Same message, different person, totally different impact. And that's part of this, is that we need to start having people who are respected by policymakers, talking to policymakers using policymaker language, bringing in people who can inspire the outcomes, and the same with every level. So I think that's when I look at it, I think all the resources we have that are untapped, all the wisdom that are in the wounds, all the energy is here. It's just a matter of harnessing it versus creating more programs, more money, more this, more that, which is what I see in the newspaper. I don't see what the newspaper has to offer as being the solution. I see us as being the solution. So.
And using the social media.
It needs to be targeted.
John had a comment.
I was actually going to change the subject slightly and just respond to the one about the revolving door. Again, this of course has been a huge issue for services and systems, has been the revolving door. And PSR interventions are the most effective interventions. We certainly have the evidence base there to stop the revolving door. So if policymakers really want to get serious about keeping people out of emergency rooms and reducing hospitalization rates and stopping the revolving door, the answers are pretty clear.
I mean, one of the initiatives that I've got Stefan right here who works on one of the assertive community treatment teams in Vancouver, one of the things that changes the revolving door is having the same people walking with that client through the revolving door and helping them learn the skills associated with that revolving door and learning the skills associated with the emergency, the skills associated with decompensation. Those skills, the revolving door, it's a sad term because it implies you go back to where you were. And I much rather think of it as a snowball gaining momentum each time you go through that, but that might require a relationship. And when we transfer people through our system, if we have our own goals and we don't think about the larger goals of the person, the citizenship goals, the journey that they're on, then we think our job is done, and then they don't get to learn as they go through. Emergency rooms, although we think of them as we want to keep everyone away, there's a great deal of learning that goes through hospitalization, goes through those things, if people are afforded the opportunity to get the Coles notes on what's happening to them.
Okay, maybe we'll move on to our second question. Yeah? Oh, sorry, audience question.
Hi, my name is Allison. I work for the ACT team as well as Stefan. And one of the things that I really feel like is effective is, oh, can you hear? Okay, perfect. That's making PSR services and programs available to people and making it an effective strategy is making a relationship with the higher management services of health authorities. If you can make it individually and personal and saying, why do we need these? How do you do this in your life? And let it trickle down to people who are clients who don't have access to certain programs, that will make it more effective. People will then understand why we need them.
Just on Allison's point, like John mentioned that PSR is understood to be a core component of mental health services, and there's discussion right now in health authorities about what core services are. There's some concern that rehabilitation is not being talked about as a core service. I don't get over dramatized, but in any case, I think we should all in our own way emphasize that PSR is a core service.
Thanks, Sam.
Sweet.
Hi, my name is Nina Wall. And I'm a facilitator with Vancouver Coastal Health on the mental health recovery programs. There's so many programs that Vancouver Coastal Health offers on mental health recovery. I work on wellness recovery action plans and the bridges and others. But often I find that within the immigrant communities, where there's a lot of mental health issues, because of stigma and lack of information, they don't know how to access the services that we provide. And sometimes some of our courses is wonderful programs that are not well attended. And so I think we need to look at the languages and cultural differences, diversity that we have in the Lower Mainland that we face is one of the challenges. So maybe in the planning that we can offer that, and then in the budget and in the planning process.
I have a comment that maybe the panel can speak to because it's probably it's got a little bit of controversy in it, I think. Peter says, promoting citizenship seems to be the key. Too often our clients/patients are outliers, and the point is it seems a little bit deeper than PSR, to be honest. Do you have any responses to that?
When John was talking about IPS, independent placement and support for employment, it made me think that why isn't our whole model citizen placement and support? And that the rapid response to re-engaging as a citizen and languaging everything in terms of that ultimate goal. And I think citizenship, what makes PSR amazing is the PSR only exists because of the consequences to a person's PSR only exists because of the consequences to a person's life that mental illness and addictions cause. If people didn't lose their citizenship, they wouldn't need this level of support. And so in the same way, PSR is directly involved in citizenship. And I also think at intake, that's where I think the upskilling and the advanced practice stuff comes in, is in teaching clinicians, teaching them how to embed citizenship into their clinical work. And that moves on, and that's what's going to create the ability for people to live beyond the effects of their illness. And if we stick to our roles, we stick to our stuff, then we can't get to citizenship. And that's part of the whole thing. If you start with human-to-human contact, that's where you'll end up with. If you start with a victim to rescuer, that's where you end up. And so that's what we need to shift. And it doesn't mean we lose our clinical competencies or our skills along the way. It means we add in an extra layer of social justice and empowerment.
Stephen, do you remember a few years ago there was an article put out by, is it Temple University or Templeton University in Pennsylvania? And they do some really great work in this area. And there was a workbook on dignity of risk. Do you remember that one?
I don't.
At any rate, it's become kind of my Bible when it comes to PSR in terms of exactly what you're talking about in terms of citizenship. And that sometimes in our roles as providing mental health services, we go too far in supporting people as opposed to moving them, or not moving people, but supporting people in their citizenship, in their community, in their neighborhood, and so forth. And it's a really good workbook if anybody wants to have a look. Can't remember if it's Temple or Templeton University. Temple, yeah.
And then there's a follow-up comment from Peter who asked your question or comment, and it says that my point was that the wider community, media, policymakers, etc., need to buy into the fact that our clients need to continue to be citizens to achieve recovery and success, which is particularly problematic in areas of forensic psych services where I work. Thanks, Peter.
We're working on a project with Van City. I'm working on a project with Van City to have, in the downtown east side of Vancouver, to try and get them to change the way that they deal with things, because they view mental illness and crime as being a linked element. And so there's tons of things we can do, but it's going to require us to leave and expand beyond what we're typically involved in. So we're going to get some consumers, we're going to get some clinicians, we're going to go into Van City, and we're going to upskill them.
A couple more audience questions, thanks, yeah.
Yes, when you're talking about citizenship, I wonder if we had consistency in training for support, that everybody that's involved pretty much is on the same page, so we can't, there's not going to be any confusion when you're talking about support.
Just while we're waiting for the next speaker, maybe I can say that if you have time to wait for some of the afternoon sessions, I think you'll see some incredible exemplars, and I'm going to just pick on the social enterprise panel. I think you'll see, if you listen to that information through the lens of considering citizenship, I think you'll see where the rubber hits the road, if you will.
I've been a peer scholar and a consumer contractor for the last several years, and one thing that I always find frustrating, and I know there's a variety of reasons for it, is turnout to different groups. Like we're discussing, there's various reasons for lack of turnout or limited turnout. But I do believe one of the factors is advocacy. Even case managers and various other persons may not always bring these things to clients' attention, or clients may not be aware of them. Still now, even though there is a lot of promotion of certain groups, there can always be more. And a lot of things aren't, people simply aren't aware of. And there's a variety of tools to get it out there. But it would be wonderful if everybody really promoted these groups that peers are running, and well, their groups as well, or whatever groups are being offered. Yeah. Thank you.
Back to Simon, and then there was a question down in front from Ruth, and
Sorry, second. About citizenship and stigma, I think there's a lot of interesting data coming out of public surveys that says when you frame mental health problems in a biogenetic way, that this actually increases stigma. That it makes the service user look like more like the other rather than a citizen. So there are some stakeholders who emphasize the importance of basic neuroscience research, but I think we just have to be mindful of the downside.
One of the things that's been really helpful is the provincial trauma-informed care guide, and having the dialogue start with the universality of trauma versus looking at the distinctions or the distinctiveness of the diagnoses between people. And that's been incredibly helpful for that exact thing, because you see clinicians getting it on a trauma-informed lens and getting the suffering and seeing the stress and vulnerability. They start to buy in, and clients as well. So I think that's been a very helpful thing around framing things. Yeah.
Hi, I'm Stephanie. I'm actually a peer support facilitator in Gibson's. We're a tertiary program and we're pretty new. So I don't know if you can see my hand, but I've got a lot of stuff to say on this, so I'm going to try not to. And I think it's impressive that we're only on question number 1, and it has caused so much discussion. But I guess, I did write it all, and I was just going to write it and just get it out of my system. But one of the things is, as somebody who's a consumer, what is this word? I've never heard it, citizenship, and it makes my hair go up. Because that implies that if we have a mental health condition and we're not doing very well, that we're no longer considered a citizen. I find that truly offensive. And I will never, ever use that term to any of the peers that I work with. And if that is part of the research, I would really ask that you take it out. Because the stigma...
That's a perfect question.
Okay.
But there's a follow-up to your citizenship question. So,
okay, so, and again, that goes to the stigma of it. I don't want to pick on you, Steve, but I've heard a little bit of the they rather than the we, because we are a community in the mental health system. So if we are doing psychosocial rehab, it's not they are learning it, it's we are doing it together. Because none of us are fully functional. You know, I might be on I'm on, you know, I have a lot of difficulties, and my coworkers can attest to that. But again, they don't necessarily see the stigma I fight every day. And this is the kind of stuff. And I think part of it that's really, really hard is the people who might be doing psychosocial rehabilitation, or in our case, recovery, don't actually get it. They think it, they talk it, but when it comes down to it, they don't get it. And as a peer, they will not listen. They think they do, they try, and I will give them accolades for that. But I was told that in order to do any peer support facilitated programs, I have to do more education. And I'm like, hello, I always say to some people, I'm a PhD in crazy. I can be teaching, but I have to take basic courses in order to do any peer-led work. So I think that's part of it. And, okay, expertise. Oh yes, I was just going to say about my expertise, but that's versus them. And I wondered too about the idea of the basic, it came out in the discussion at the beginning, about the idea of basic life skills. Basic life skills are not good enough. Because yes, right now we have people that are doing ADLs, we're working on helping people brush their teeth or whatever, but that is not enough. And you can't work and you can't live without having more than the basic living skills. So I wonder if that's maybe another word that we can reframe, because, you know, I'm missing some of my so-called basic living skills according to that list, but I've got some really good other skills. Okay. Yeah. Oh, and serious mental illness. That's another one. What does serious mean? It's just like, you know, I got some serious poop going on in my head, but there's other things that aren't. And it's a continuum, right? And it's also something that does not stay. Right now, I'm doing semi-well. Tomorrow, who knows? You know, so, yeah, so what is considered serious? So I will leave this now. I actually didn't intend to say so much, but I got excited. So thank you.
That's Stephanie, yeah?
Yes.
Thank you, Stephanie. And follow up to some of those fantastic points. There's a question, quite simply, by the way, Stephanie, Wendy Michigan from the island says amazing speaker. And thanks to that speaker. Here's a point blank question. What is the definition of citizenship that we're using?
You know what? I'll tell you. I'll be very, very honest. I've had formal training in rehabilitation, and this is a very new concept. So I've been very quiet, and I've been taking all of this in. I've never heard of citizenship, right? So what I've been sort of hearing now, we started off with, let's see, my memories. Talking about bankers and how we need to, get them on board. I think from the start, we actually have been talking about stigma, right? So we really, that's the punch. Like, we have been talking about reducing stigma in the community. Bottom line, I think as a psychiatrist, I experience stigma because of the work I do. It's called double stigma, right? So there is an official term called double stigma, right? So anything to do with psychiatry and mental health has stigma, right? So I think I don't know what the definition of citizenship is. I'll be very honest. I've not really read a lot of literature on it, but I have a feeling that it kind of stems from that stigma and inclusion in the community, right? Allowing people to live their lives and achieve their goals without having this big cloud over them or because they've been a consumer. So this is what I understand. I want to add. I don't know if anybody else has anything.
I apologize if I was if the term is offensive or the like. Or if anything else said is creative divide. The purpose of the term is really to, for me, as a healthcare worker, is helping people understand that our role includes healthcare, but it's broader than that, and that the terms of our work are based on the client's goals and the client's journey. So the other way I could talk about citizenship is the 5 service domains, which cross all the different areas, 6, I'm not sure how many there are, that John talked about this morning. So it's, you come in, at the stage when you come in, you may be struggling. You may need a lot of healthcare. You may need a lot of help. But I don't define you by that. I define you by who you are and by where you want to go. The tools I use, if I'm a healthcare, if I'm a counselor, I might use counsel. If I'm a physician, I might use medicine. The ultimate goal, though, I'm not going to cap the ultimate goal based on my one little piece of the pie. So that I guess I should have defined that at the beginning. Because there are people who aren't going to go on to become politicians, or there are people who are going to struggle, and I want to honor that. But it's just the idea that we see, and if you look at the philosophy of the values, we see that everybody has value, everyone has strengths, everyone has gifts, and that we can work on those, and then we're humans working with humans, and we have different roles, and that was my intent. So I apologize if I went astray with some obscure word. So I apologize.
Maybe I'm not on the panel, but if I can say one thing. I absolutely hear where you're coming from. I think it's a fantastic thing to dissect the language and to have a question about what are the implications of what you're saying. And so I can see the perspective from both sides. As somebody who's sort of latched on to this idea of citizenship as it's been presented, if it's of any benefit, interpretation for me has always been about recognizing that the stigma produces limitations or instills limitations on somebody else. And so therefore the idea of supporting somebody in their quest towards citizenship is supporting somebody in their most basic rights. And that's what citizenship to me means, is that people are entitled to the full spectrum of rights regardless of personal experiences, varied as it may be.
From the audience, there was also
Just a comment from online, which may segue into some later conversations. I just wanted to point out that Steve Harding, who I know is a social worker in Fraser, says rather than training, quotes, peers to provide support, maybe, quotes, peers should be training professionals. Of course. This year, this is the third year of teaching the practitioner competencies course. I don't know, are folks in here in that course? So every year it's getting better and better, the dialogues and the discussions. And this year we have this, I feel like there's a swell going because we have a number of people with lived experience. We have a number of people with high credentials in this program, and everybody's teaching each other. They're talking about so it's not that there's a consumer only talking about that part. It's everybody's talking about themselves and how they interface in the system. And it's not about, I would say it's about the right people teaching the right things at the right time. And so there's lots of wisdom from professionals, wisdom from peers. It's about opening it up that we can all be teachers.
Fantastic.
Okay, hi, my name is Georgianne Malcolm. I am not a mental health worker, I'm just a member of the mental health community. And I was diagnosed with paranoid schizophrenia with anxieties. And one of the things that really helped out in the hospitalization is the spiritual care. Having people come in and I know this is kind of a sidebar from citizenship and such, but spiritual care is so important. And we have seen the finances decline in this area, where people are not just reaching out for understanding goals and understanding what programs that are out there for them in the outpatient program, which are fantastic, but they also need the spiritual care aspect. And we see a lot of people who come in from different citizenship from other countries, like Hinduism and Muslims, and they're all coming, into the psychiatric ward with mental illness because of the tragedies that are happening in their countries. And so it's through spiritual care that we also have that wonderful aspect to see rehabilitation. So I was wondering if that could be another component to embrace the churches and start talking in that area, because that's what I've been doing. I've been talking to churches, just Christian Life Assembly out in Langley, and saying that we need to start embracing this mental health and become partner up next to mental health Fraser Valley, and we need to do something in this area. So something to consider.
Can I just add, just follow up from the spirituality? People might not know this, is just adding, saying there's actually an early psychosis intervention conference in March in Abbotsford, and the theme there is all spirituality, so just if people are interested. So that's again coming to the point that we are doing all of that. I mean, that's happening within our communities, it's just that nobody knows. And how do you access those events and what's going on, right?
I'll just add two things. A lot of work is happening in Vancouver Coastal Health. Maybe some of you who work in those areas or receive services there know about worked on a group of people receiving services, and a researcher, Dr. Sharon Smith, have developed a model, have really articulated how to go about having conversations with people in that area. So I think it speaks very much to your experience of that being a positive support for your own recovery. And my understanding is that with Razor Health, they have engaged this person to do some work in that health authority as well. So thank you for that focus. I agree with you. I think it's deeply important. Thank you.
Hi, my name is Amanda Berg. I'm a peer-led workshop facilitator coordinator, and I just wanted to let people know about the Wellness Recovery Action Planning sessions that we have going on. We have one starting February 5th at 1 p.m. at Gascona Team, which is 3:30 HEE. We have a Bridges course that just started. I advertised it in the Coffee News. We had 17 people register for that, but only 7 or 8 showed up. So, and that is at Ravensong Midtown Team, which is 2450 Ontario Street, and it's on Mondays at 3:30 p.m. We also have a wrap at Kids Team starting February 5th at 1 p.m. There's also a Your Recovery Journey course going on Mondays at West End Team 155 Robson at 1 o'clock. And we also have a support group every Thursday of the month at 2 p.m. at 520 Candy. And so there's a lot of support groups going on. And I also co-facilitate a Hearing Voices group with Renee and a bunch of people. And it's for people who experience voices and visions, and it's at Grandview Woodlands Team on Broadway, and it's the first and third Friday of the month at 2:30. So, you know, you can go on the, I'm trying to think of the Spotlight on Mental Health website. We also have a Facebook page. If you go to Spotlight on Mental Health, you can like us and find out all about the event. Thanks.
Thanks, Amanda. Sorry, just before the next question, if there's a next question, I just wanted a couple comments from online. One regarding stigma and one regarding spirituality. So Sandra Fairchild comments, I don't mind the term citizenship, but I'm bothered by the word stigma, interestingly enough, which attaches the problem to the illness of the person who has it. I would like us to drop that word and always use the words prejudice and discrimination instead, since they make it clear that the issue is with people who have irrational negative biases.
I think it's fantastic.
Follow up to the spirituality question. This is very cool as well. So a reference from the Marisol McCrae, this from the island, I hope. Dr. Anna Wong McDonald spoke about using the Lieberman model at Hollywood Mental Health. Apparently she quoted 90% success using PSR approaches alone, but 100% when she added spiritual care to practice to the PSR.
Cool. Ruth?
Wait, we need the microphone. Jill?
So I want to go back to something that was mentioned a little bit earlier about the loss of some rehab services because they're no longer considered core services. And I'm wondering about how we can use communities of practice and developing that concept within PSR to strengthen our basis to speak to the health authority and the funders to show the benefit of our work. Just different directions.
Yeah, just for the benefit of the folks online, the question, in the face of loss of core rehabilitation services, how can the community of practice band together to advocate on behalf of these services with funders? Maybe there's a panel. Yeah, Vicki, you have something to say about this.
Hi, thanks. Yes, I just wanted to preface this with a few things. First of all, I am the chair of PSR Canada, and it's a volunteer position. So my day job is actually, I'm an executive director of a community mental health and addiction program in Kingston, Ontario, which covers all of Frontenac County. So I want to thank you for having me here and want you to know that I understand how passionate you are about what you do, because I think that's one of the main bonds that brings all of us together, is that we believe very, very strongly in this. And I really wanted to talk to a little bit about effective strategies and engagements and so on and so forth, but I also wanted to share with you in terms of where some of this is going to help us, where I think PSR as a philosophy is going. Is this an okay time, John, to talk about that? Okay, what we've been working very, very hard, okay, let me back up a bit. When we talk about engaging with people, about what we're passionate about, there are times that we have to be very clear that we're engaging them in a way that they can understand. Because sometimes, frankly, they don't get it. And it doesn't matter how often, Stephanie, or that we say to them, da-da-da-da-da, the little ears are just going to go, whoops, I don't understand this, I'll just keep going my own way. So one of the things strategically we have to do, and we do this on a national basis with the PSR Canada board, is we think nationally, how are we going to promote this so that we can continue to support all of us on the front line to make things change? Because unless we think strategically about it, we're going to run into this wall constantly. One of the things we knew we needed was we needed the competency document. Now, some of you have talked about specific programs that are no longer around. Well, what we need is the proof to say, this is what works, and this is what John has been working with the framework. And we also need to say, people who do this work need to have these competencies. Now, I'm sure that when you look at this document, a lot of you are going to see yourselves and what you do well reflected in this. But to the folks who are, policy geeks and all those folks, no, I'm not talking about you guys. They need to see it in language that they can understand. So for 2 years, a bunch of us volunteered across Canada to put together this document. It was released at the September PSR conference. It's very thorough. It's been, done all the scientific stuff that John insists on, which is wonderful. So it's good and it's ready to go. And you say, well, that's fine, Vic, but now what? Well, you see now, that is a tool that we can take to our partners, to the policy geeks, to the others to say, you talked about recovery-oriented. And this is what it looks like, because everybody's got a different idea out there, right? They don't, and a lot of people don't get it. The PSR has been doing it for years. So this competency document is going to back up what you guys have been doing, and it's going to say something to the policy folks, to the folks who are saying, how do we roll out recovery? Because that's what they're all talking about. They're all saying, how do we do this? And they're doing it in bits and pieces. And so what PSR Canada has done is said, okay, this is what we need to do, and education is key. And I'm jumping into one of your questions, Matt, later on, if that's okay. When we talk about how are we going to move things forward. Well, unless we can educate the rest of the folks who are struggling to understand it, and then they can, and so that they can implement it in their programs. We need to say, this is what you need to, these are the kind of people, it's all about relationships. These are the kind of people with these particular skills that are going to move forward recovery. Fine. So what we have done is on a national basis, we have gone to the Mental Health Commission of Canada. Now at this point, they're our best bet for national partners. They've got provincial, territorial reference groups. I'm sure you guys are aware of those, and you've got somebody involved with them. But they're the ones who have put out recovery-oriented stuff in terms of their strategy. PSR is mentioned in their strategy. We have a number of provincial strategies that say PSR, and we've gone to them and said, okay, look, we've got competencies. All these people are coming back to you and saying, how are we going to measure that we're doing this? Well, we've got a document that says if you want skill sets, if you want staff who can do this, these are the competencies and why don't you partner with us around that? And that's exactly what the Mental Health Commission has done. On Tuesday, they're going to be signing a memorandum of understanding with PSR, PS Canada, to say that they will work with us to roll out recovery-oriented services. Hey. Yes. This is very exciting. They have also given us, and like I said, PSR Canada, thank you for being here. We are running on a shoestring. We're all volunteers, including the fact, I paid my own way out here because I wanted to be here because I know it's such a great place. But we don't have any money. So what we said to them is, okay, the next step is we've got a wonderful education plan. Probably some PSR BC folks are on that education committee, I'm not sure. But we have put together an education plan based on how to roll it out around the competencies, right? Get competencies, you got to have an education plan. We've got a comprehensive education plan together, and we also have a dream. The dream is we want to set up a national registry. It will never be an education, or it won't ever be like a provincial college of nurses or something. But we will put together a national registry so that when people say, I know what PSR is, they will provide, and I don't know how it'll happen yet, an exam, whatever, I'm not sure. Some people will probably be grandfathered who have already, the education and all that kind of stuff, or experience, whatever it is. At any rate, we want to put together a national registry so we can say to providers, you want to make sure you're doing recovery-oriented practices and services, you make sure that your staff are on this registry. So we have received now from the Mental Health Commission, as of last week, a $10,000 grant to hire somebody to go and scope out and see how we're going to put together that registry, not to actually do it, but how we're going to do it, and how we're going to meld that whole education plan into it. So when we're talking about, we hope to get that done, hopefully within the next few months. This is something I've been talking, actually the guy who it was really interesting, when I got on my flight to come out here, I walked through, and one of the guys that I've been working with from the commission, one of the senior leaders, said to me, "Oh, hi, Vic." And I went, oh, hi. As soon as I got to my seat before the flight, said, "Turn off your little things," I'm emailing saying, "Can we talk when we get to Vancouver?" Because I know he lives in Victoria. Before you catch your next flight. He said, "No, I don't have any time if you want to talk on flight." I said, "Yeah, let me know." He and I stood at the back. You know where the loos are on the plane? Yeah, we stood back there for almost 45 minutes talking about next steps and how we're going to roll this out. It was a great flight. So, you know what? That's the way we do things, isn't it? That's the way each of you make things happen, wherever, whatever. But the thing with the health authorities and all the other folks, if we can say to them, we have a national competency document that's backed by somebody with a lot of credibility, the Mental Health Commission of Canada, we're going to be able to register people on a national registry. We can say to you, we've got education around this, we're going to get noticed by them, right? We're going to come, and that's why I said talking on their level, because on their level it's, well, yeah, you guys are all out there, but you're not organized, and how do I know you really know what you're doing? Well, now we're going to have that credibility. We're going to have that you get from that kind of system of accreditation, certification, whatever you do. So I really think, I'll end now, that this is where PSR is going. You are on the leading edge of a wonderful movement. You will be the first ones in through that door. We're just trying to, the cracks there, we're trying to push it open. And if those of us who've been around, and I'm looking, if we take Garrett, and I, and John, there's probably 130 years here of experience, which is really scary. I started my agency 32 years ago, 2 weeks ago, and I want you to know I was 10 at the time. But you know what? We're going to make sure that the road ahead is going to be a whole lot easier, and we're going to get the notice of the people who do the funding, of the policy geeks, of everybody else, but we really need to work on this together. Thank you.
Okay, we only have 10 minutes left, and I want to make sure we get a few more questions in from the web as well as in the room. Maybe we can move on to the questions. We've kind of covered some of these. Yeah, let's talk about this. I think this is fantastic. How can we make the connections to establish an active PSR community of practice? So this is where we want to get your opinion. We want to get your ideas. How are we going to stay connected? We have this website. We're planning to do these trainings, these webinars, and group sessions where we get together and we discuss the key issues. But how do we keep this more? How do we keep it growing and going? In a way that sort of reinforces all the ideas that Vicky's just put forward. So I'll throw to the panel some thoughts and ideas how we can reinforce this community of practice, and then please, what do folks have to say?
And to go further on that certification, for all rehabilitation practitioners, from the very beginning of the US CPRP or CPRA, and even before that, there has been a continuum so that there is certification for all rehabilitation practitioners in the US, and they have to have that certification in order to become part of the community of practice. Is that perhaps one of the requirements that Canada might be thinking about? That's one of the things that I initially thought might need to be done in Canada. A lot of the time we don't have enough people who are respectful of the whole PSR and need to recognize the whole mind, body, spirit practice that needs to be so combined to be caring about other people. So I'm just wondering if that's part of it.
Absolutely. The CPRP, of course, many of us have looked at that and have done that, participated in that. But what we decided we needed was a Made in Canada version, because there were a number of things that CPR didn't do that were part of who we are, culturally and otherwise. So yes, the idea is that that we would have a Made in Canada version, encourage people to take part of it. And I wanted to answer Matt's question, and I'll do it this way: what each of us can do, in which I'm constantly doing, to the annoyance of many people, is I'm saying, so, do you have a membership in PSR Canada? Because there is nothing cheaper, as far as I'm concerned, to move forward on making sure that people do get it and do understand it. So yes, at some point, where that's going to go, of course, we're built differently than CPRP is. And where it goes, I think is really going to be dependent on the PSR membership. Everything I've told you right now has all been done by people within PSR. Where we go next will also depend upon the members of PSR Canada. We'll be talking about it next September again at our annual conference. Certainly you guys can talk about it here. Your rep is John on our national board. He's supposed to bring those kinds of things back, which he does. We've got a very strong, closely connected board who really try and work together. Well, they do work together very effectively. So yeah, so where we go from here depends on where you want it to go.
Lots of encouraging support from the web, very inspiring. And also just to sort of delineate, in our conversation, we're talking about a community of practice. We're talking about a community of practice in the broadest, most inclusive sense. So again, everybody in this room and everybody who's got any stake in the province is going to be considered as part of our community of practice. As part of the sort of professional function of the advanced practice, we do and have established an advanced practice advisory committee, which is comprised of individuals in key positions throughout the province in mental health and substance use services. And we're hoping to use that advanced practice advisory committee as a hub to relay and collect information to our broader provincial community of practice, so that no matter where you are, you have someone that you can email or you can phone that says, this is what's going on in PSR where I am, this is what's going on in recovery, I'm seeing these things and I'd like to see this, or this is amazing, tell everybody else about it. And so that information can then come back to us, and then we can use the website as a communication tool and email lists and such. So if you have any ideas as well along that line too. We got a question from the audience, one Darren Lee.
Yep, that's me, that's Darren. I do have just a comment maybe on some ways that we can use the community of practice in that website. I'm a part of the EPI Early Psychosis Intervention Community of Practice, and they've been effective in a way to bring about that connections throughout across BC. And what they've provided is the website where you have an opportunity to connect in a way you showcase what your profession is or what kind of involvement you have with EPI. So the same thing could be done with PSR. We have vast areas of expertise within PSR in this room. And I think to just showcase where you have that expertise just on a bio part of, like, so you have a page of all the members and you can connect in that way. So having emails that you can connect with as well. But also there's opportunities for people to sit on panels and do webinars as well and showcase what's important in PSR within their area of expertise. And so they do it approximately once a month, where they try to gather somebody from a different part of or different expertise within PSR, and then, within EPI in the case that I'm speaking of, and they present on that. And I think that could be a possible direction that you guys could take with the PSR community of practice.
Excellent. And we do, in fact, currently are in development of a directory, so a stakeholder directory that's going to be accessible on the website. So folks will be able to just go on, register, say who you are, where you're from, any information about yourselves, links to your own resources and whatnot.
Yeah, one concern that I really have is I'm not going to mention program names because that's going to make me sound like I'm against the program, and I don't. I know that it's an evidence-based practice, wonderful program, but I think at times there's some changes in budgets and stuff where things that are working are maybe having to be sacrificed at the expense of other PSR programs, and that really, really bothers me and concerns me, and I'm afraid for some of my peers because I don't want them to lose access to these PSR programs because they're not deemed sick enough or they're doing well enough that they don't need it anymore. I think it should be up to them to decide when they're well enough that they can function without it.
So I think that about wraps us up for the morning.
Yeah.
Thank you guys, everybody, so very, very much for coming out. We just have some closing words before the break. Wait! Sorry, I shouldn't have said, wrap this up. From our co-chair, Jill Walker, and to everyone online, thank you so much for joining us for our inaugural webinar attempt, and look forward to many, many more of the similar, and using the feedback from this session to improve quality in other sessions. So a couple comments from Jill, and then we'll break for lunch.
Matt, and thank you to the panel, and thank you to the audience, and thank you to the webinar. It's really exciting to the webinar folks to read your comments as we've been chatting. We're going to break down for lunch. So lunch, when you exit the lecture hall, it's that way. Feel free to eat in here. The AGM will be in here for half an hour, or in the room, or out this way. And then refer to your schedule for the breakout sessions in this afternoon. We'll be breaking up now for the next 2 sessions, and then we'll reconvene here for an update from Debbie on peer support certification. We'll see you back here then.
Sorry, Jill. Just before we leave, let's say a big thanks to Matt. What a guy.
Yeah.